Welcome back, everyone. We're going to start the afternoon off with our first panel, the Pleural Tumor Board panel. We had a few schedule changes, staff changes, I should say. We had a few physicians who had some issues with getting here, and so we have a few substitutions. Our moderator for today is going to be excuse me, Dr. Melina Marmarelis. She's the medical director of the mesothelioma program at Penn Medicine, as well as a thoracic medical oncologist. Next to her, we have Dr. Adam Bograd, who is a thoracic surgeon with Swedish Health Services. Next to him, we have, sorry, I'm moving my list around. Okay, next to him, we have Dr. Mehmet Altan. Dr. Altan is a thoracic medical oncologist at MD Anderson. Next to him, oh, thank you. Next to him, we have, thanks. I have to go to my other page. Next to him, we have Dr. Mike Offin, who is a medical oncologist at Memorial Sloan Kettering, where he's the co-director of the mesothelioma program, and also a thoracic medical oncologist. Welcome, everyone, and I'll let you take it away.
Great, thanks so much. Everyone can hear me? Hi. Great, I'm Melina Marmarelis. I'm a medical thoracic oncologist at Penn, so I did not come from very far. Thanks for everyone for being here. So this is meant to kind of give you a glimpse of what happens when we have a question about a patient's treatment, surgery, different aspects. We bring it to a group of multidisciplinary physicians. Usually a medical oncologist is there, a surgeon is there, a radiologist, sometimes an interventional pulmonologist, and we discuss as a group kind of what the best next step would be. So we call this a tumor board. And so we're going to present two cases today like we would at a normal tumor board and have a discussion, and then we welcome your questions, either about the cases or about tumor boards in general. All right, so what are tumor boards? We talked about who participates. Generally, we give the background of a case, so there's a very specific way in medicine that we do this, so you'll kind of see a little bit of how we think through it, and all our brains work the same way. We need to hear the information in the same order. And then the recommendation is made to the treatment team, but then it's a discussion with the patient. So I would say, usually the recommendations are followed, but it's something that then we go back and discuss with our patients. All right, so for the first case, I'm going to pass it along.
So I'm Adam Bograd. I'm one of the thoracic surgeons from out in Seattle, a little bit farther than Penn. These slides were created by Taylor Ripley, who unfortunately got stuck, so I'm going to do my best to go through them, and everyone feel free to chime in. So the tumor boards typically start with just general case presentation. You give some patient demographics and presentation, so that's how the flow of this will go. So this is a 78-year-old man with some shortness of breath. He went into the emergency room. They got some chest imaging, and they noted some fluid in the pleural space. That's fluid outside of the lung, but inside of the chest. They got some additional imaging with a CT scan and a PET scan. So there, I know where I am, there is a large variety of places people get their medical care. There's big tertiary medical centers, there's small community centers, so the workup for a new effusion can vary pretty significantly. So I guess that's always a good first question, is what is a typical workup for new effusions?
Well, I think we see a new effusion. Of course, we do like to get the imaging to figure out if it is one site or two site. Second thing, we examine the patients and what the clinical symptoms and what the chronicity is, and if there are any additional constitutional symptoms with it, fever, weight loss, or any other. And of course, the most critical thing is to get a sample from the effusion and look at the biochemistry and looking at if there is any signs of cancer cells inside of that fluid. And these are the first steps. And usually what has been done is when we drain this fluid, we spin and we try to collect sediment, and we look under the microscope, do some specific stainings to figure out if there is a cancer cell, and if there is a cancer cell, what might be the origin of that cancer. And this is generally the first step. But of course, it can be by itself not adequate. I think we will be discussing further. But for example, in mesothelioma, only 1/4 of the fluid samples can carry malignant cells, the cancer cells. So by itself, it might not be diagnostic, but when we look at it, how urgent, how critical, the chronicity, additional symptoms that may come up with, and after that, the analysis of the fluid is the first step.
Just to add to that, I mean, talking to the patient about kind of underlying risk factors and exposures. If you see a person with a pleural effusion who, you know, has symptoms or concerns for exposure for tuberculosis, or you think they have heart failure, or if they were a pipe fitter in the Navy, you may go down a different algorithmic kind of thought process. But as my colleague said, you will sample the fluid, you take a look. There are different criteria to analyze it. A negative sample does not mean that the space itself is pristine. And so further evaluations may be needed. And I'm sure that's probably what we'll be talking about moving forward.
How many times do you sample an effusion before you're sure?
Our institutional standard is if we have high clinical suspicion after even 1 or 2 negative taps, we would go for a surgical intervention to adequately sample the pleural space.
Great. Thank you, guys. All right, you walk us through the imaging.
So this is a CT scan of the previous patient we just mentioned. The images is as if they're laying down and you're kind of looking up from their feet. So the top of the image is the front of their chest, the back. Towards the bottom is their back of their chest. Towards screen right is actually the patient left. Towards screen left is the patient right. So you can see on the patient's right side, screen left, there's some fluid, there's a little bit of pleural thickening, and then one of the more subtle things that you can actually see is you see some asymmetry in the anterior posterior diameter of the chest. It's almost like one side is collapsed down a little bit. On the right side is a PET CT scan. That is a CT scan that's fused with some metabolic imaging where you get essentially sugar injected into you. It's tagged to a fluorine atom, and then when that sugar gets used as fuel, most cells use sugar as fuel. It sends off a light particle or a positron, and that functional imaging gets fused on top of a CT scan. So things that glow tend to take up more fuel than the cells around it, and one of the things that uses more fuel is cancer cells, and so that indirectly it implies that there's something abnormal if it glows brighter. So you see a little bit of hypermetabolic activity along the right lateral chest wall, posteriorly and laterally.
Ask you a question about this. So I know you're not a radiologist, but that was a very good job, but just a spot read. Is this a high burden of disease, just from this?
No, this is not a CT scan that I would look at and say there's a lot of disease burden there.
Any other comments about the imaging? Okay, so what do you know from these images, and what would you do next? Since this might come to you normally, I'm gonna have you start that conversation.
So I think the findings are concerning for something going on in the pleural space, and in particular if somebody's had a pleural effusion before. So I would probably go directly to a pleural biopsy. We do them thoracoscopically. You can do them percutaneously, so from the outside with the interventional radiologist putting a needle in, but I think you get a ton of information from thoracoscopy or putting a camera in the chest. You can really see disease extent in terms of what's on the parietal pleura, which is the undersurface of the chest wall, what's on the visceral pleura, which is the pleural surface surrounding the lung. You can see within the fissures how much disease there is, which is the dividing spaces between the lobes. in the lung. You can see how much is on the diaphragm. So it really gives you a good idea of disease burden, and you can take really good samples. And I know sometimes when you're doing FNAs from the outside, you can sometimes have a little bit of confusion as to the histologic subtypes, which is really important actually for figuring out treatment strategies afterwards. So I would vote for a pleural biopsy, but I'm a surgeon. That's like asking the pizza guy what's for dinner. He's going to tell you pizza.
If I could just ask one more leading question, would you, during the initial diagnostic procedure for a pleural effusion NOS, go right to pleurodesis? Yeah, and I think that's important because we will see that in the community, which can limit my surgical colleagues' abilities. So, do you want to maybe?
Can you explain what pleurodesis is?
I'll let the gentleman who does it, if you'd like.
So a pleurodesis is a procedure where you want to try to get the lung to stick up against the chest wall, and the purpose of that is to obliterate the space that sits between the lung and the chest wall. That is a potential space. That potential space can fill up with fluid. Fluid building up can be really symptomatic. It can give people shortness of breath, chest pain, and so what he was mentioning is while you're there, you're in the chest, why not just do it? In theory, it sounds like a great idea to just do it. However, if your initial biopsies are non-diagnostic, you've kind of hosed yourself in going back. It makes it really difficult. So I personally do not. I wait for a diagnosis, and then the other thing that you can assess at the time of surgery is, does the lung actually come up, right? Because if you want to try to pleurodese somebody, the most common thing we use is talc. I'm not sure what you guys use elsewhere. Yeah, but we use talc. If you can't get apposition between the lung and the chest wall, then the talc's not going to work, right? Because you can't get things to stick up. And so you start thinking about other things like Pleurix catheters and things like that. So I personally don't initially until I have a definitive diagnosis.
And I agree with that. The other reason to bring it up is if there was going to be consideration for a section once a diagnosis was made.
So I personally think pleurodesis makes the subsequent surgery easier. Yeah, we can talk about it, but I think it actually makes it easier.
I was going to say,
Yeah.
my surgeons say the opposite. I guess it's apples on.
Yeah.
So I think probably the summary there is that pleurodesis can be really good for fluid management, and actually we do it quite a bit, and it's not a contraindication to surgery. So, but I think we're saying you should be thoughtful about when to do it, essentially. All right.
All right, so it looks like Taylor did a right VATS. I'm going to say VATS for video-assisted thoracoscopic surgery because that's really a tongue twister. Drain the fluid and you biopsy the pleura. So you take this device and you just sort of nibble a little bit at the pleura. This is important. You actually need to make sure that your biopsies are deep enough because you have to document invasion. If you just do these little superficial surface bites, you can sometimes get a non-diagnostic biopsy, so that's important. I was always taught to biopsy down to things that you either see fat, muscle, or it bleeds, and usually that gives you an answer. So a mesothelioma diagnosis was obtained from pathology. Second part of this is important too, and it gets to functional testing to make sure people are fit enough to undergo surgery. So it sounds like the cardiopulmonary testing was fine. And then the last line is important because you need to stage people appropriately. So I am pretty conservative about surgical resection. I think it really needs to, in 2025, going into 2026, it really needs to be the right person you're operating on. And so I am a very big proponent of very, very aggressive preoperative staging. And so it sounds like they checked some of the lymph nodes in the chest and did some biopsies in the abdomen with laparoscopy to make sure that there was no disease spread.
Okay, so you gave us a lot of information. I think the workup sounds very similar to what you would have done. Is there anything else you would do?
So I typically stage people pretty aggressively, right? So there's staging by imaging, so you saw some of it, right? So a PET scan. I very aggressively do lymph node staging. So I trained doing bronchoscopy biopsies for lymph nodes. It's one of the few instances where I do mediastinoscopies. because you want to make sure you're actually biopsying a lymph node and not pleural tumor. So there's a way you can put a camera just beneath the breastbone, go down, and you can biopsy some lymph nodes that typically live along and between the airway, where the airway splits. And so that's one. You want to make sure you're not operating on, you're not getting yourself to an instance where you're doing a big surgery on somebody who may not benefit from the surgery. And then one of the more common places where mesothelioma can be outside of the chest is intra-abdominally. And so you want to check to make sure there's no intra-abdominal spread, in particular on the surface of the undersurface of the abdominal wall, the omentum, which is some of the fat that lives in your belly. And then I in particular look for transdiaphragmatic invasion, so I look at both diaphragms. Typically, if the tumor has invaded through the diaphragm, there's probably going to be a pretty high chance that there'll be spread in the belly or intraperitoneal dissemination. So you really want to get a good look at the diaphragms. I guess we're going to talk about it because there's some slides in terms of surgery. I tend to stay away from extrapleural pneumonectomies. However, I work everybody up as if they're going to get one, because if you're in the operating room and you have to transition your surgical plan, you don't want to be wondering, is this something they're going to be able to tolerate? So, yeah, so one of the surgeries involves removing the entire lung. One of them involves not removing the entire lung. So if you need to transition from going from a lung sparing surgery to a remove the whole lung surgery, you don't want to be wondering in the back of your mind, okay, is this person going to actually tolerate this? I didn't get, X or Y or Z tests, which are impossible to get afterwards, right? So I tend to get everybody stress tests, tend to get VQ scans on everybody, which looks at the perfusion to the right and the left side of the lungs. And I also tend to get echoes on everybody to make sure they don't have pulmonary hypertension.
One piece of additional information that wasn't on the other slide was the type of mesothelioma. So I will steal a page out of Hetty Kindler's book. I don't think she's here yet. She'll be here tomorrow. Mesothelioma can come in two different flavors. It can be vanilla or chocolate or a swirl of the two. So vanilla being epithelioid, the most common, about 70% of pleural disease will be epithelioid. The chocolate in that case would be a sarcomatoid or a mixture of the two, biphasic. For the most part, surgery is most appropriate in patients with epithelioid disease. There can be equipoison and epithelioid predominant biphasic. But I think that's a big decision point for us, would be the type of meso to make a decision if surgery makes sense up front.
Yeah, I agree for sure. The other thing that you were alluding to, but I just want to be more explicit about, is that we do really want to make sure the disease is isolated to where we think it's isolated. So, we saw on the PET scan that it was just those few little spots that were lining up along the lining of the lung. And one of the spaces that's really hard to see on imaging is the abdomen. So actually, prior to any surgery, our patients will get a surgical laparoscopy to look in the abdomen and make sure that it hasn't spread, because it is very hard to see it on imaging. So that's one extra check, just to make sure we are dealing with what we think we're dealing with. Any additional comments on this part?
So Taylor had a trial open at the time. I tried to get this open at our hospital, but I couldn't. I failed miserably. I think you guys have it or know about it. Yeah, chime in if I mess this up. So this is a study that was that Taylor had open at the time. It's neoadjuvant. ICI is immune checkpoint inhibitor. Those are drugs that work in a certain pathway that help the immune system in mesothelioma. So it's abbreviated NEMO. So if I say NEMO, that's what it is. So this is for mesothelioma patients, stage 1 to 3, good functional status, which is that ECOG 0 to 1. Any histology, right? So that touches on what you said, sarcomatoid, biphasic, and epithelioid patients. The patients were broken down into two separate cohorts, or two different groups. One, cohort A, got durvalumab and tremelimumab. I think I pronounced that right. So these are, durvalumab is a PD-L1 inhibitor that blocks a certain pathway. PD stands for programmed death, so it stops the T cells from dying when they interact with tumor cells. And tremelimumab, I think, is a CTLA-4 inhibitor. Yeah. So that's a chemo-sparing regimen, I would say. Cohort B involves chemotherapy and those 2 different immunotherapies. Then they get surgery. If you tilt your head, it can be one of the 2. It can either be a pneumonectomy, an extrapleural pneumonectomy, which is removal of the lung, or an extended pleurectomy decortication, which tends to be what Taylor prefers. And then since we trained at the same place, it's also what I prefer. I think the best way I could explain what a pleurectomy decortication is, there's a slide next, is if you think about your lung like an orange, and the pulp is your lung, skin is the tumor, and you just sort of peel it off. So there's certain inclusion criteria. You got to make sure that you're putting the right patients on trial. You can't just put everybody on. These are people that are potentially resectable. I think this is where tumor board is helpful to discuss patients, right? You got to figure out who is resectable and who is potentially resectable and who's not. They have to have a path diagnosis, so it has to be confirmed. The imaging can't show any disease spread outside of one side of the chest, which is what you just mentioned. Can't have any obvious chest wall invasion or invasion into the mediastinum. The mediastinum is just the center of the chest. You need to have a surgical evaluation by surgeons who actually know a thing or two about mesothelioma. I think some people have a very nihilistic view of mesothelioma, and if you ask a surgeon, some of them just say no way, which I definitely do not think is the right thing. On the flip side of the coin, you can't find a surgeon who just operates on everything. That's also bad. All histologies were included in this one. So these were all 3. This is the chocolate, the vanilla, and the swirl. All of them. And they could have either no nodal disease detected or nodal disease that's isolated to either the same side as the tumor in the hilum, which is out towards the lung, or the mediastinum. The nodal staging system for meso is a little bit different than lung cancer. So this is a picture of a extended pleurectomy decortication. So the slide on the left is getting the parietal pleura off from the chest wall. So this is really the first step in the surgery in determining whether or not somebody's resectable or not. So if there are instances where you think somebody's resectable and you get into the operating room and they're not. And it is a very simple test. If you get between the chest wall and that tumor rind, if your finger slides, it's resectable. If it doesn't slide, it's not resectable. Because that implies that it's T4 and there's some evidence of chest wall invasion if the tumor doesn't come down off the chest wall. And then the right side is peeling the orange skin off of an orange. So the underlying reddish pink structure is the lung, and the, I guess, salmon pink is, with the hand peeling back, that's the tumor rind that's coming off. So it's two components. It's taking tumor off the bottom of the chest wall as well as peeling tumor off of the lung. And then typically for an extended pleurectomy decortication, it involves removal and resection and reconstruction of part of the diaphragm and often part of the pericardium.
Surgeons have sometimes described it to me as actually peeling the white pith off of an orange instead of it's harder than the peel. Yeah. And has anyone ever gotten all of the white pith off of an orange? No, it's very hard. So I think it's not a bad analogy for the surgery either. Okay, so this patient has, checked all of the boxes that we've asked for in terms of being a surgical candidate, and they received 3 cycles of the chemotherapy and immunotherapy, so they must have been in the combo arm. They had surgery with removal of the disease, and then they continued on immunotherapy after. And I guess this patient is thankfully doing very well, so that's great. Dr. Offin.
We don't have NEMO open at our institution. We also lost the fight to get it funded to be open. This data was actually published, like the little sister of this now randomized trial was published in CCR. So just kudos to Taylor's group. Really interesting trial with a lot of interesting work came out of this. One thing that's not mentioned here, because I don't think it's necessarily spoken to on the trial, but there's a radiation oncologist staring at me. When we talk about surgery, we talk about usually a multimodality or a 3-pronged approach. We've addressed 2 of those, something that goes in the body, something that comes out of the body with a surgeon, and then there's usually something else. That something else is somewhat institutionally specific. Some people will do intrathoracic chemotherapy. Our institution and Penn, I believe, are much more inclined to do imprint or IMRT, which is radiating where the peel used to be. The reason being, you can't peel all the white pith off. I can't promise my medicine can kill all the white pith, but at least we can say that if there's any white pith left, the best we can do is to try to radiate it away. So it's important to understand that these kind of group discussions aren't just surgeons and med-oncs. It's not just surgeons, med-oncs, and rad-oncs. It's supportive care, pulmonologists. It's a large group that kind of comes up with this multi-pronged approach for a patient like this.
There are a few things I also want to review about this patient's case and in general. So one of the reasons we review our patients in multidisciplinary group is, again, we would like to get a synergistic or at least additive effect from the contribution of these different elements. That is because generally, if we do even a very aggressive surgery, we cannot cure most of our patients because we cannot get rid of it all. And the intent is how we can increase the cytoreduction, how we can try to get rid of most of the resistant tumor clones by surgery, by radiation, so systemic therapies can be more effective. And this decision was a little bit based on earlier stages of data related with surgery. And what has been historically studied is for patients who had surgery followed with aggressive conservative therapies, such as systemic treatment or radiation, did better than historical controls. But of course, there was a bias because we were selecting the fittest patients for surgery. And 2 years ago, there was a study that has been published that make all of us to hesitate to surgery as much, but there was some flaws, or at least we believe it was not in the right perfect setting. But that study for patients who were treatment naive, diagnosed with pleural mesothelioma, underwent surgery, or they did get systemic treatment, and patients who got surgery after that got additional therapies if needed. But there was not a significant advantage. Actually, there was an increased early mortality in the surgical arm. But when we look at the patient selection, the selection criteria were not very typical. So some of the cancers, some of the biologies are more aggressive, and we generally do not offer surgeries most of the time. That is biphasic and sarcomatoid. And there were a number of patients who had that histology. The second thing, we know lymph node involvement shows what is the extent of the disease, or at least a surrogate of it. The tumor is trying to get out of the chest. And there were a number of patients who had lymph node positivity. The other thing is surgeries were done in surgical centers, but those centers did not have enough expertise, at least some of them, which probably explain why the outcomes were inferior than most of the centers that we expect to see in terms of outcomes, 30, 90-day outcomes from the surgery. So those are the reasons, at least few reasons, why the current highest level of evidence does not support surgery. We still believe surgery can play a role in the treatment of mesothelioma, but we need to select patients. And that is one of the reasons we discuss our cases in tumor board. And the other thing, it is going to be important because we cannot cure our patients in general. We will talk about different strategies, how we can try to convert this disease more of a chronic disease. And one of the key things is how we can decrease the disease burden so that we can alter or slow down the progress of the disease. It is why we'll be talking about these different strategies. And this is going to be also an important discussion for the medical part, what we can do in terms of combination, and if we are going to do maintenance or not, because you need to consider the risk and the toll to the patient, but also what might be the benefit in terms of these treatment decisions. The other thing I would like to highlight is neoadjuvant treatment. So this is a systemic treatment that is given before surgery. We have a lot of experience in different cancers, in breast cancer and lung cancer, and that is the success that we are trying to replicate in some of these studies. Giving systemic treatments before the surgery provides a couple of additional benefits. Number one, patient tolerance is better because after a surgery with recovery, sometimes patients may not be able to get these therapies the way that we plan to deliver. Second thing, if we give these drugs up front, when we do surgeries, we can see in real life what the treatment response may look like. So that is an important aspect to it. And the third thing is, of course, if we have a good global systemic control of the disease before a surgery, it is likely that we may have a better outcome with the cytoreductive approaches. So that is one of the reasons we've been trying to bring these neoadjuvant studies. Not only we can hopefully improve the outcome of surgery, which has been, again, at least in high level of evidence, not as good as we would like to see, but also if we can identify patient-specific therapies that works well, because when we remove the cancer under the microscope, we can see how many cancer cells died, what is the viability of the leftover tissue. And the third thing is, because we won't be able to get rid of all the cancer, we will be leaving some micrometastatic disease. If we have a good systemic control, can we have better outcome?
One of the things I just wanted to touch on, he mentioned, what is the goal of the surgery, right? Because I think the most common question that I get after really any surgery is, did you get it all? Hey doc, did you get it all? I'm like, for these, I'm like, kinda. So the goal of surgery is what's called a macroscopic complete resection. So what is that? Did you remove all tumor that you can see with your eyeballs, and is the only thing left behind microscopic, which is an R1 resection. So that's really the goal of surgery. So that's sort of a tough conversation afterwards. Like, did you get it all conversation? And you think you did, but you probably didn't. There's probably microscopic disease that's left behind, which is why when I read papers about mesothelioma, if they cite R0 resections, I immediately trash the paper. And then something that you touched on about the MARS-2 trial. I have a tough time really altering my thought pattern and practice based on that trial, considering the large percentage of patients in that study who got operated on who I would never, ever operate on. And most mesosurgeons would not operate on.
I agree with that. What I would say is, so MARS-2 is the trial he was alluding to it's a European-based trial. And I always try to be politically correct. It was appropriate in the time and geographic environment it was done, but we have a different practice pattern here. We have different surgical centers and mesothelioma centers of excellence here. We could sit here and talk about it until I'm blue in the face, why we also still think for the properly selected individual surgery makes sense. But I think that's the most important thing. This is not the type of a procedure or decision that is going to be totalitarian recommended to a patient based on kind of conflicting literature. So you talk to a team to discuss, do they think you're healthy enough to go through this procedure and have good quality afterwards? And do they think realistically they can get enough of this out to make it worth your while? But at the same time, if the person sitting in front of me says, listen, I don't want a week-long hospital stay for that surgery, it's not something I personally want at this juncture, it's not definitively wrong to hold off and forego the surgery. So it's definitely a shared discussion. But in our center and centers like it, the people on the stage, those types of centers, we offer it to people that we deem operable well enough to tolerate the surgery and resectable. After our surgeons do their full evaluations, they think they can get enough out, we would offer it. For instance, the predecessor of the NEMO trial, patients lived well over 2.5 years, give or take, as compared to MARS-2, which was 18 months. And the trial that I'm publishing now was 36 months. So again, it's about patient selection. And to say whether we're better at surgery or we're just better at picking patients, it's really hard to say. But I don't think MARS-2 is the end of surgery. It's just the more thoughtful utilization of surgery.
So I'm going to open it up for questions. This is our case about surgery. So we'll move on. The case after this will be about systemic therapies. So let's focus the questions on the surgical cases. So I saw you in the back. Oh, you, yeah.
In other approaches to cancer, people have talked about concomitant tumor resistance, and there's poor, from what I can tell, evidence for that for mesothelioma, but not very much. What do you think? Do you think that's a possibility?
Are you asking about like an acquired resistance mechanism to therapy?
No, it's the idea that many of these cells secrete, a large tumor will secrete a tumor-suppressing hormone for other cells, right? I know it's been shown for certain kinds of lung cancer, for example.
Yes, I mean, the tumor itself, by definition, can secrete different, what we can think of as hormones or chemokines that may affect the way in which the body can respond to certain drugs. Surgery itself, the actual manipulation of the pleura in the lung, can also affect what we call tumor microenvironments. So it makes it very difficult to study. So if you get a biopsy sample for us to figure out what is the tumor secreting, the needle itself or the scalpel itself may alter what it's secreting. So it's a very nuanced discussion. But I would say, extrapolating from the experience in lung, having lymph nodes and native tumor inside and exposure to immunotherapy during that course seems to be more beneficial than not, because you still have the proper immune milieu. Now again, that is much more conjecture than anything else. And in a rarer tumor like this, we're likely going to be consigned to conjecture from other tumors.
I think I understood that you said that if the lymph nodes were already infected, that you're not a candidate for surgery. Is that in all cases? Also, what if you also have nodes inside your lung?
Yeah, so it depends how extensive the nodal involvement is and which lymph nodes are or are not involved. So if you have, microscopic involvement of one lymph node that is out towards, not a non-mediastinal lymph node, a hilar lymph node, something that's more out towards the lung, we probably still would proceed forward with surgery for that. Conversely, if somebody has a lymph node on the opposite side of the chest from where their tumor is located, right? So if you're on the right side of the airway, but your mesothelioma is on the left side of your chest, that's not somebody we'd operate on. Or if somebody has multiple stations that are involved, that's somebody that we probably would not operate on. Or if there was a lymph node involved in the abdomen, we wouldn't operate on them. So it's nuanced in terms of who you would and wouldn't offer surgery to. I don't think there's a one-size-fits-all plan for mesothelioma, which I think it's important to present all of them at tumor boards. So every new mesodiagnosis that I get, I present at tumor board, because it's important. There's a lot of nuances, and so I wouldn't say all lymph node involvement is exclusionary for surgery, but you have to be very thoughtful about it, and you have to make sure the lymph node disease burden is low.
It also is a good reason, if there's a lymph node involved, at least where we are, and I assume many other institutions, if surgery was going to be considered, that's a person we would almost de facto recommend some sort of medical therapy first, because we want to prove we can control this disease that's already starting to move a little bit before we put somebody through a large surgery.
You mentioned you don't do surgery on biphasic or sarcomic tumors. Why is that? Or what if it's discovered that after surgery it is now biphasic, not epithelioid? So,
as a clarifying point, we don't routinely do it on patients that have any chocolate. If it's a swirl, vanilla mostly though, so like an epithelioid predominant, so 90% epithelioid, 10% sarcomatoid, in a healthy, fit person who understands the risk and benefit of the procedure in that setting, we may still well offer it. For what you're describing, this is a conversation I have with every patient before surgery of, I think right now you have vanilla based on where the needle went. But when my surgeon takes out the entire thing, we may be surprised and upstage or change the diagnosis. So for us, we've had patients that happens to, of course. We can get some hints off of PET scans sometimes, but a lot of the time we will give the patient the benefit of the doubt. For what it's worth, PET scans, if like you have a spot that's super bright and everything else is low level bright, those super bright spots may be a different flavor. But if the biphasic component was found after surgery, in my practice, I'd be curious to hear what Melina would say, that may influence my post-surgical plan towards an immunotherapy approach, because we know in the advanced non-surgical setting, immunotherapy is more beneficial than chemo in the initial setting. So if I have a person that I gave, let's say, standard chemo to, we did an extended pleurectomy to cortication, and we found a hint of a biphasic, that's reason for me to think about pivoting towards immunotherapy in the after-surgical setting.
I think the other thing I want to add is that, that it comes from a historical adage that patients with biphasic or sarcomatoid mesothelioma did not do as well. And so surgery ended up just delaying their systemic therapy, and they sometimes didn't make it to the systemic therapy, and so it just didn't serve them well. Now with immunotherapy, with dual immunotherapy, the playing field has leveled quite a bit. And so, some of these trials actually are designed with the question of, now can we do surgery for biphasics and sarcomatoids since we have dual immunotherapy? I know this one was, and there's another one at Mayo Clinic that was asking that very specific question. So I think it's changing a bit.
And I think that's a key point. Standard of care right now, we don't normally do it if we know a priori, but this is the exact setting for the trials. Because if we prove that immunotherapy has changed the landscape, nothing would make me happier than to offer patients with those specific diagnoses this procedure.
I agree. From a standard of care standpoint, it's not routine to offer surgery if you know up front that somebody has either sarcomatoid or sarcomatoid predominant biphasic. But all of us who operate have I call them the oops biphasic patients, where you thought they were epithelioid going in, and then on final path, there's sarcomatoid components. So I think on a trial basis, it's fine because it's an important question to ask, because the older data, those studies weren't powered to look specifically at sarcomatoid patients. So I think it's important. I think you can do it on a trial basis. I wouldn't routinely be doing it. I don't think that's a great idea. But I think that needs more information.
One last question before you do the next case.
I actually had two. One would be easy. What if the family or the patient, him or herself, tries to convince you to do it even if you don't see them as, they say, I don't care if I die, I don't want to live this way. Just would you try? And that's one question. The other is, this is primarily what I've heard is more for pleural. What about the people with peritoneal or other types? Oh, is that going to be closed? Okay.
Yeah, the peritoneal part will defer to tomorrow's tumor board, because I think that's actually
I'll be back on stage for that tomorrow, but I can talk to you after this if you want to.
But the first question you asked about surgery is interesting, and I'm curious about everybody on this panel's view. My general feeling is that because surgery is not a cure, and we have a lot of other systemic therapies, if I don't feel that someone is a good surgical candidate, then I'm not the surgeon, so I'm not the one actually doing the scalpel, but I certainly wouldn't be recommending it, and I don't think our surgeon would proceed.
And I would agree with that. These are not easy surgeries. Our surgeons, after they're in there for 8-10 hour surgeries, our patients could be admitted for several days for pain control and management. These are not necessarily easy procedures that we would go into just because an individual personally wants it if we don't think it's going to benefit them. That would be my thought.
Yeah, I agree. It's usually a conversation between the care team trying to figure out if surgery is the right thing to do. They're very, very difficult surgeries. They're difficult on patients. They're very difficult on care teams afterwards. So to do them for the sake of doing them, I personally think is a terrible idea. But there are, sometimes patients make you reconsider your viewpoint on things, right? And sometimes the no isn't no ever. It's just a no right now, right? Somebody gets, I have a patient, my first year of practice, very large treatment, very large burden of disease. They got treated with dual agent immunotherapy. They had a really good response. A year later, there's just like 1 or 2 spots on, towards their back that were just causing a lot of pain. And they already had a bunch of radiation for another reason, so they couldn't get any more radiation. And so we ended up operating, right? So there's reasons to do it on the line, and a no is not a no always. And sometimes that no can turn into a yes. But typically when you have a lot of people agreeing up front that surgery is a bad idea, it's usually a bad idea.
I think also in this day and age, with data that is a little bit equivocal about how much surgery is beneficial, we're all looking for reasons not to do surgery, right? No, I'm sorry. That's we're trying to figure out why surgery is a bad idea. And if we get to the end of that questioning and we say, wow, I really couldn't think of a reason why it's, not a bad idea, then we proceed. But we've become much more picky. Okay, I'm going to move on. This we're about to answer, so we can talk a little about that. Okay, so this is our next case. So this is a 76-year-old woman. She presented with shortness of breath, and she was found to have a left-sided pleural effusion. Again, fluid on the outside of the lung on the left side. ROS means review of systems, so these are like the symptoms that she reported. So she reported some weight loss, about 6 pounds. She said that when she was walking, she felt more short of breath. She had a cough, and she had her bowel movements were loose. She said she was having some diarrhea. In terms of her past medical history, she actually had giant cell arteritis, which is an autoimmune disease. She'd had a small stroke in the past, and she had a history of eczema. She was a never smoker. She worked as a school teacher. She thought maybe she knew that her classroom had undergone asbestos remediation during a period of time that she was the teacher there. She did not have a family history of mesothelioma, melanoma, kidney, or breast cancers. These are some of the cancers associated with BAP1. And on exam, she looked, pretty good. Her vital signs were stable. I couldn't feel any lymph nodes. When I listened to her lungs were clear. They were moving. She had decreased sounds at the left base of her lung, which was probably the fluid that was there. She had some tenderness to palpation of her left central back, but I couldn't feel a mass. And her performance status was a 0, which basically means she's up, walking around. She doesn't really have any symptom that is limiting her activities during the day. Okay, so we have a left-sided pleural effusion. We still don't have a diagnosis at this point. So what would we do next? We've talked a little bit about this, but can we have somebody walk us through?
For the most part, this type of a diagnosis, you may be in a primary care office, a pulmonologist's office. You don't have a diagnosis yet, you just have fluid. So a lot of the times, kind of as we discussed before, imaging and then sampling of the fluid. And then depending on your kind of what we would call pre-test probability, but that just means your suspicion, even if that fluid is negative, you may still want to go towards a more invasive approach to sample.
Yeah, I would get some dedicated imaging first, and that would probably guide what to do next.
Okay, you asked for imaging. We have it. All right, so this is a PET scan again. I'm going to use my laser pointer. So in this one, the patient is actually, it's as though you're standing up, even though all of you guys know that when you go through a scanner, you're lying down. But I find people it's a little easier to look at this way. So a little different from our other case. We see there's quite a bit of activity here at the left base of the lung. So this is all presumably disease that's taking up the dye. It does seem to be isolated to that area, but it's fairly extensive. When we look at the axial section, so now the patient is lying down, their feet are coming out towards us and their head's on the other side. These are slices like a hoagie. We're gonna go back. You can tell we're in Philadelphia when I call it a hoagie, right? So we can tell here from this pleural mass that it's these little white things along the side are ribs, so it's going in between the rib, maybe even into the rib, so this is chest wall invasion. And then as we go towards the bottom of the diaphragm, we can see there's some lymph nodes here that are probably on the other side of the diaphragm. So there's probably a lymph node that's taking up the dye that's in the peritoneum, in the abdomen. Anybody want to make any comments about the imaging?
A large tumor burden in this location is particularly hard to clear in the operating room. In the sulcus, where the diaphragm goes down and meets the chest wall, and then more specifically medially, where the diaphragm comes over towards the center of the chest. It's a little hard to see on there, but you got to trust me on this. The esophagus comes up there, the aorta is there. There's a lot of other structures that are there medially and posteriorly. So a large tumor burden in that spot in particular tends to be pretty hard to clear in the operating room, unfortunately.
Okay, so I think what we know from these images is that the disease is fairly extensive in the on the left side of the chest, and it might have spread into, you know, 1 or 2 spots in the abdomen. So what would we do next? Mehmet, maybe I can have you walk us through.
So what we know from these images, this is a pretty extensive involvement. So we saw in both sides of the diaphragm, and there has been some local extension. We would like to understand what the biology is. This is highly suspicious for cancer, and we need a tissue diagnosis. And once we identify the diagnosis, then we, of course, need to start thinking about what the patient's current state of health and how their end organ functions are, so that we can start thinking about what medical management can be considered. So basically, blood work, clinical exam, and tissue diagnosis will be the next step.
Great. So we did get a biopsy. It was a surgical biopsy again. So the pathology came back as the epithelioid type, so the vanilla in our analogy there. And then there was staining for PD-L1, which was 50%. That is a marker for immunotherapy, not a great predictor in meso, but we can talk a little bit about that. And there was BAP1 loss within the path, not necessarily a germline BAP1, but there was loss there. Anyone want to comment on any of this? Dr. Offin?
Just that I would make sure it was sent for pathology, and then I'm assuming during this procedure they probably did something to help with the effusion. So in general, you know, we can talk all the science and the fun stuff on the stage, but the patient in front of you is what matters. So if the person's got fluid there and they're short of breath, we want a diagnosis, we want to figure that out, but the first thing is help the shortness of breath. So during a procedure like this, I would assume they would have sampled the fluid, placed a catheter if needed. To me, that's like the first step. The first step is try to help with the symptom.
That's a great point. Okay, any additional information that you need? Maybe go back to you, Dr. Offin. Do you have everything you need to make a decision?
Organ function, blood work, and patient preferences are going to be paramount here. I think looking at the imaging, to me, this is leaning towards initiation of something through the vein first, before we would consider anything else. And to figure out what makes sense, we know it's the vanilla, which in the modern setting is what I like to say dealer's choice. We have 3 FDA-approved options, and theoretically they're all on an equal keel for epithelioid. So that's dual immunotherapy, chemo by itself, or chemo plus immunotherapy. I have strong inclinations one way or another, but that's personal preference. All 3 of them are reasonable in epithelioid, and it's going to depend on the patient's goals, the patient's wants, and what's safe to give based on the labs.
So I have a question for you guys, actually. So one of the things that's come up a lot for us is potential autoimmune problems in giving immunotherapies. Do you guys have any absolute no's, gray areas, and ones that you're like, that's not a big deal?
So I have and do give immunotherapy to patients with underlying autoimmune disease in close collaboration with the rheumatologist if it's well controlled, and depending if hopefully it hasn't required anti-inflammatory biologic type drugs. For a giant cell arteritis, it to me would really depend on what vessels were involved and how active it was. It may give me an inclination that if I had the option of chemo, to start with chemo because of the concern for toxicity for this individual. There are lots of, like, I always like to say, Melina and I are both chefs and we both cook the same dishes, but we have slightly different recipes. So there's different ways you can dose the drugs, different ways you can lean a patient into the medicines. So it's not a direct contraindication in this patient, again, just based on the information given. Ones that I would usually say definitively no would be an underlying autoimmune lung disease where they're on oxygen. I cannot risk loss of pulmonary function with those medications. Barring that, destructive rheumatoid arthritis, which is debilitating quality of life. but in reality, it's talking to the patient about risk and benefit.
So just for everybody in the room, so giant cell arteritis, if it flares badly, you can lose your sight. Okay, so it's one that you in my opinion, it's one you don't want to mess with. This particular patient had been diagnosed within the last year and was still on steroids.
And a couple of additional things about that. So giant cell arteritis is involving generally the vessels that are going to the brain, and one of the common symptoms can be vision loss if it is an active inflammation in this vessel, but also it can cause stroke, and sometimes it can, because it's kind of inflammation of certain vessels, it can increase the risk of aneurysms and dissections in major vessels. So this is definitely a very concerning diagnosis. And we do not know very well what are the incidence rates when we give immunotherapy, how many patients or what is the percentage we may flare. But what we know from immunotherapy, even in patients who never had this problem, this has been in case reports a reported potential risk of an immunotherapy. It's very rare, but we know in a biology, probably this is something immunotherapy can flare. So that is why when we have different treatment options, definitely this pre-underlying autoimmune disease is one thing that can help you to decide what should be not probably a first treatment option.
All right, so this patient actually had a pretty long journey to get to us. So they had been, the imaging findings actually were 3 months prior to when I met them. And so I got new imaging. And the summary of the new imaging is that the disease in the 3 months actually had grown quite a bit. And there was now clear abdominal disease, whereas before we thought maybe there was a lymph node. So that's just the update on the imaging. So I think we've answered a little bit of this, but certainly we're thinking more about how quickly we can start systemic therapy. I do think about these people that have quick disease growth, a lot of weight loss. I do think more about chemotherapy for patients like that, because I think we see some faster responses with chemotherapy. So again, I think we're all kind of leaning that way. So this is what ended up happening with this patient. They had 4 cycles of chemotherapy. The thickness along the left side really decreased very nicely. The lymph nodes decreased in size. The abdominal lymph nodes, the abdominal implants decreased. And she felt it much, much better after starting treatment. So I wanted to provide an example of chemo, because we talk a lot about immunotherapy. But for some patients, I do think that chemo is a really important tool, or at least part of what we can do. I'll pause there for comments.
Did you happen to get any sequencing? Or I would just say in general, in mesothelioma, the guidelines and our feelings are, if there's adequate sample and the patient's agreeable, doing sequencing off of the tumor, that can help inform clinical trials, can also be somewhat prognostic. If we find certain genes, we may know that maybe a bit more of an aggressive biology. It may open up, matched therapies later on in terms of a trial setting. There's also the possibility of the inherited genetic panel that can be considered. That may also have prognostic implications. We'll talk more about that in the peritoneal session tomorrow. But BAP1 may mean a little bit of a different biology. But there are other inherited conditions that go along with mesothelioma. We say it's around 10 to 13% of the time, regardless of known or suspected asbestos exposure. There could be an inherited family predisposition. And that could be anything from BAP1 to the BRCA breast cancer gene to the Lynch syndrome colon cancer gene. It's not just the classic one we think about on our test questions. So I would routinely recommend a broad-based genetic panel for those interested.
Yeah, so this patient did get a genetic panel. They did not have a BAP1 somatic mutation, so we did not proceed to germline testing. I believe this patient had a CDKN2A mutation, but not MTAP deletion.
So they were BAP1 wild type?
They're wild type.
But, so they lost it on IHC, though?
On IHC, yeah.
So that's an important, interesting thing. You're going to see BAP1 potentially in reports in like several different places. Seeing the word BAP1 doesn't mean it's an inherited BAP1. So this patient's tumor lost BAP1 expression in the cell, but the gene in the tumor was normal, and the gene they were born with was normal. So they actually lost it beyond the DNA, when the DNA was becoming a protein. And so when you see BAP1 in your report, it doesn't necessarily mean you lost it at birth.
So the next question I have here is kind of what happens next. And I think this is an area we don't have a lot of data for. So this patient got carboplatin pemetrexed. They got 4 cycles. They tried to do a trial where they flipped a coin for patients like this, and they said, okay, continue 1 chemotherapy or just do surveillance every 3 months with your scans. And that trial didn't accrue quite enough patients. They accrued about 50 patients, but from what they were able to see, there wasn't much difference between continuing one of the chemos and actually just watching. So I think we all have slightly different practices about this, and probably it differs patient to patient, but I'd like to ask the medical oncologist what they do.
I feel like this can become very frustrating to the patients, that when they see 2, 3 providers, everyone have a different opinion. And that is pretty much because we don't have the existing data, and we are trying to extrapolate the information from other tumors or from our experiences. But at the end of the day, when we have these conversations, we need to talk about what are the justifications. So this is a patient who has a quite high risk for immunotherapy-induced toxicities. So we know the standard of care for the second line for this patient, if at that point, after a discussion with the patient, it's going to be chemotherapy or a dual checkpoint inhibition. And we know in dual immunotherapy, tox rates are higher than 1. And that is not an easy decision to go for a relatively weaker chemo versus dual checkpoint inhibition. So the one question that is going to come up is, in a patient where the second line treatment options are less than ideal, how we can prolong the duration of response. And I think that is one of the reasons in patients coming with these comorbidities, it is important to talk about how many cycles of dual chemotherapy should be given, and if we need to give any maintenance chemotherapy. So as we discussed, the clinical trials that has very limited data about the benefit of continuation of pemetrexed in the maintenance setting, it is because those studies did not enroll much and their endpoints changed. And at the end of the day, we also had to see a patient population in 2 different arms receiving a little bit of different treatments like cisplatin versus carboplatin, and different histologies like sarcomatoid epithelioid. So there were some imbalances, which makes that information very hard to understand and interpret. But what we know for certain maintenance therapies in certain settings like non-small cell lung cancer suggest, well, there is a cumulative side effects related with chemotherapies in that setting. There can be a prolonging of the containment of the cancer, what we call progression-free survival. This is specific to lung adenocarcinomas. So I think in this situation, it would be reasonable to consider a maintenance strategy with the hope that you can prolong the duration of control of the disease. So, this is one of those situations you can consider methotrexate maintenance, and if the patient have a good tolerance, again, it is the same thing with radiation surgery. In order to decrease the disease burden as much as possible, you can consider the induction regimen, which is dual chemotherapy, to be longer. But there are a couple of variables we need to be very careful of considering. Number one, what are the cumulative toxicities of these treatment, how the patient is feeling with this treatment, because some of these toxicities can be irreversible. The second thing, how much of a deepening response we are getting from these therapies. So after 2 cycles, if you are really reducing the cancer burden in the sequential scan, if you are seeing you reach the maximum cytoreduction, you reach to more of a plateau from that tumor shrinkage, it suggests that maybe the treatment is not as effective as it has been, because you are trying to kill these cancer cells with chemotherapy but chemotherapy generally kills most of the chemotherapy-sensitive clones, and whatever left behind may not be as responsive to chemotherapy. But along these lines, I think this is a patient we need to consider if there's going to be 4 or 6 cycles of carboplatin pemetrexed, and if a pemetrexed maintenance can be considered with the hope to prolong the containment of the cancer, and that is what I would suggest.
I also think it's important to consider if their recurrence or their progression is symptomatic or not. So if she has, for instance, progression in the chest wall with significant pain, I think it'd be a good time to bring in other treatment modalities like radiation or protons or whatever. I think that's important. I know I sometimes fall into this trap of treating imaging rather than the person. So I think you have to think about, is it a symptomatic recurrence also? That's important to consider.
Just to give us, a slight counterpoint to like the use of pemetrexed maintenance. With all the nuances therein, there is a negative randomized trial for the use of pemetrexed, which did not improve survival or outcomes and did lead to a detriment in quality. And so it has to be a very select person you would consider it for. My counterpoint being, we define the reutilization of the chemo double. If somebody's cancer responded and didn't grow for 6 months or a year, it depends on who you ask, but many months of benefit before the cancer regrows. If you're going to continue a maintenance, you have to be mindful if that maintenance drug hurts the kidneys, hurts the blood count, hurts the person's functional status and quality, and the cancer recurs on the maintenance, you may not be able to repurpose the platinum again. And so it's a very delicate tightrope walk, but what I would say is, as it stands right now in the guidelines and in my head, it's a rare person that I tend to continue on pemetrexed maintenance for that reason, but this is a very unique case where immunotherapy is much less attractive. And so thinking outside of the box here is by no means incorrect.
And these are the concern that we generally have in terms of chemotherapy, that cumulative toxicities can be detrimental by themselves as well. That's why before each treatment, the patients are seen by the providers, and we'll get the blood work and do clinical exams. Because, for example, for pemetrexed, there are a couple of toxicities that are very relevant, which is fatigue, bone marrow suppression, and problems in the kidney. So if we see any of those toxicities, we know that things can get worse. The other thing that we know, again, that comes from non-small cell lung cancer data that also maybe give a little bit more clarity about the maintenance. Even in patients where we believe there is a benefit from pemetrexed, like non-small cell lung cancer, adenocarcinoma, in 85–90% of the patients within 1 year, we have to stop it either because of disease progression or because of an organ dysfunction or because of progressive worsening of the side effects. So in no means this is not indefinite, but again, in case to case, I think these are the nuances that makes us think about how many cycles, if there is a role for maintenance, because there is not a really high level of evidence that's available that can give us more clear answers.
Great. So I ended up recommending 6 cycles of carboplatin pemetrexed for this patient. And so she's just completing that. I'm going to see her in 2 weeks. So I appreciate this was actually just me trying to get everybody's opinion about what to do. But most likely we're not going to do pemetrexed maintenance. She's starting to feel the chemo a little bit, and I think she would appreciate a break. And I don't have great evidence that it's going to benefit her to continue the pemetrexed. So I think that's what we're going to consider. And she knows we're talking about her today. She's not here, but she knows we're chatting about her. So I'm going to open it up to questions. Yes.
What makes you choose carboplatin over cisplatin?
Yeah, great question. I can start off. So the original studies were done with cisplatin. There are some people that are still very much cisplatin loyalists, and they feel that this is and actually Dr. Offin comes from an institution that is generally a cisplatin loyalist. They have done retrospective studies, meaning they looked back and they said, okay, this person got cisplatin, this person got carboplatin, and they compared them, and there's no difference, okay? Now, that's not a perfect comparison because you're not, flipping a coin and making sure all the different characteristics are equal, but I generally only use carboplatin. It's a very rare situation that I'll use cisplatin, and that's only post-surgery in a very young patient.
As a quick aside, I am not a cisplatin loyalist, and I see many of my patients in this room who can probably attest to the fact that I use carboplatin quite frequently. It's the person in front of you. If you have no reason not to use cisplatin, then I would say there is some anecdotal experience in older papers where cisplatin had slightly better outcomes, but those tend to be healthier people who can tolerate cisplatin. You treat the person in front of you, and I would say the vast majority of people I see will get carboplatin because it's likely the one they'll tolerate the best.
My question is, in your experience and everything I read, people are in their 70s, 60s, are you starting to see younger people coming in?
So this is like a little plug to Prasad Adesumilli. We have a paper under review on that exact topic. So we have polled what we called young diagnosis, which we defined as patients less than 50. Very young is less than 35. We've identified 500 patients seen at our institution over the years, 200 or so of which we were able to annotate. The youngest patient I have ever personally seen and managed was 8. This is a disease with a bimodal distribution. We tend to think of it as a 60, 70-year-old Caucasian male veteran. That's not the case. We have to really start integrating our understanding of a younger patient population's needs into clinical trials in terms of fertility preservation, in terms of all the things we know from other malignancies. And we have to have a high level of suspicion in a younger individual with a recurrent pleural effusion that meso's not off the table just based on demographics. So it can happen in a younger population. We anecdotally see they may be more or less responsive to certain drugs. They may have slightly different genetic backgrounds. Those are active fields of investigation. Right now, everyone is treated by the same playbook, but whether that's the right thing, I don't know.
I'll make one other comment, which is this is a very hard disease to diagnose. And so we're getting better at it, actually. And that's probably contributing somewhat to us seeing it in younger patients as well.
There were comments about continuing with Mextred as a maintenance drug, but none of you talked about Avastin. Did you touch on that?
Yeah, I was hoping someone would ask that question, so thank you for being the plant. So the patient we talked about did not get Avastin because of their history of giant cell arteritis, which is a vasculitis. And Avastin is an antibody that affects blood vessels, okay? But generally, if I were giving carboplatin and pemetrexed, I would give Avastin with it. And you're right that there is data to continue Avastin in the maintenance setting. So if this patient had gotten Avastin, they would have continued Avastin in maintenance.
As an aside, if there's a person in the room or family member, people you know who couldn't get Avastin maintenance, because there are lots of lists of reasons why Avastin may be less attractive to continue. The trial that showed Avastin was beneficial showed it was better than chemo by several weeks when you added Avastin. It was enough to get it into the guidelines, and it's something I use routinely. But I like to say to my patients, if there's a reason you can't get it, the chemo is the part I don't want to miss out on. I'd love to add the Avastin when we can. I agree, I give it, if there's no reason not to, I would give it.
First of all, thanks. This is fascinating and so important, this information, because each one of us, I think, has had a scan happen and then gotten in front of an oncologist, and this is going on behind the scenes. We don't know this. This is not explained to us how this happened. I heard a mention of a tumor board one time. So it's fascinating to see how it works. I hope it happens every time. My question is, how do I know, because there's too much to talk about, okay, with an oncologist, honestly, with this disease. I would need hours of time to satisfy every question we have about the disease. It's unrealistic. Here's what, they did germline testing on him, and they did tumor marker testing on him. How do I know that the treatment he's currently receiving receives the consideration that I just saw happen up here, where you discussed among yourselves the tumor marker results and the relation to the germline results? We don't get that communication. How do I know his treatment is guided by those tests that were paid for and sit there in his portal, but nobody's ever talked about them with us?
I would advocate you speak to your clinician. These tests, those results belong to you. And so, again, there's never enough time in any individual visit. And I'm not.
Well, I was hoping you'd say, assume that it's done.
I would never make the assumption. I mean, again.
Assume they did it and just didn't talk to you.
I mean, I would hope and assume that, people at centers like this, yes, they are appreciating the results, they're reviewing the results, they're integrating them into their decisions. But the most important thing to integrate into a decision is the person getting the treatment. So I do think it's important. If you have a question about a fancy diagnostic test, that is not time wasted to bring up. So I advocate that you bring that up. Like, that's an important, like, for instance, not to get in the weeds here, there's a new gene we're very interested in terms of clinical trials. We've only found out about that gene of being interesting in the last few years. So if I have a person that was diagnosed 3-4 years ago and had a genetic test, we never tested for that gene on that panel. But that panel may give me a hint because there's a gene that co-deletes with it. And a patient bringing that up to me and saying, like, hey, what's going on with my genetic sequencing? You know what? Maybe that scratches an itch I wasn't thinking about. And so I think it's very important. Constantly advocate for yourself. These tests belong to you.
Is that a good way to word it? How are the tests being used to confirm?
I mean, my patients will come in and be like, are my genetics result back? I would like to discuss them. And that's it. I mean, that's as easy as it needs to be. It's like a CAT scan. The assumption is you should be discussing them.
And I think, the reality is right now for standard of care treatments, other than some small nuances, we aren't making decisions based on the molecular testing yet. Most of the time we're making the decisions is about clinical trials. So just to be explicit about what Dr. Offin is saying, so we're talking about things like MTAP deletion. So these are maybe words you're starting to hear, MTAP. So you can ask, have I been tested for MTAP deletion? Or NF2 loss, that's another gene, NF2. And those are going to set up a patient's eligibility for certain clinical trials. So that's the type of conversation that we're starting to have, but this is all really new because we're finally seeing some drugs that, potentially can target these things.
Can it biopsy or? I'm sorry. It's kind of relative.
So the genetic testing done 3 years ago, is it still relevant?
I mean, genetic testing, like any test, is relevant in context, right? So if the gene you're interested in knowing about, like let's say it's a trial, let's say you walked in the clinic and said, am I eligible for this company's drug that says I must have this gene being wrong to get on? If it was in that panel, then that's still relevant. If it wasn't in that panel, then there are several ways you could actually go back and try to recapture genes and do, like using old specimens to get new answers is theoretically possible. But I would say it's still relevant, but if, it was a new gene or you've had several intervening treatments in between, a repeat biopsy for repeat testing is also reasonable.
He's asking about somatic testing, and I think what Dr. Offin's saying is if you've had treatments that you may need.
The treatments we use in mesothelioma, unlike lung cancer and other things, don't have as much evidence that it could completely change the genetic makeup of the tumor that could, like, this gene wasn't there, I gave this drug, I would expect this drug to make this gene get messed up, and I expect to see it now, so let me biopsy it. We don't have that amount of equipoise like we may have in lung cancer. Like if somebody's on a pill, the pill stops working, you expect there's going to be resistance and you repeat the biopsy. With that said, I do routinely, and if there's an easily accessible, like let's say somebody has a lymph node that we can feel or something just under the skin, doing a repeat biopsy for repeat genetic testing, if you've had lots of treatments in between, is reasonable considering the current state of our clinical trials.
So I just had surgery and there's a lot of biopsy material. Should I request another genomics?
I mean, again, without knowing your specific situation, depending on when the last genetic testing was done, how old that panel was, it's not unreasonable to discuss.
I can't chime in too much about fancy genetics and stuff like that, but you should never feel shy to ask questions to your doctors. And if they get frustrated with you asking questions, you should get another doctor. Serious, totally serious.
You might have alluded to this, but I'm not quite clear. The genetic testing, I'm assuming for most people, was done when you had fresh biopsy sample. And I know people can request slides and at least pick up, a gene mutation or two, but can you really get a full genetic workup from saved samples that are in a block, or does it have to be fresh? Like
we're very fortunate with the current technology, like banked slides, which are basically like wax embedded slides that are shelf stable, could be put in a box and saved for 10 years. As long as there's enough cells in there, the technology exists to extract the DNA. It doesn't have to be fresh material to do that. Often it's actually fixed in slides first, and then DNA is extracted even on a fresh sample.
And in mesothelioma, because we do such big biopsies a lot of the time, we're doing surgical biopsies, we're actually lucky that there's usually a lot of tissue that's there. So in lung cancer, that's not always the case. In lung cancer, we sometimes have to, decide what we're going to use the tissue for, but I haven't really had that problem with mesothelioma.
Quick question. Just having all of you on the panel, first of all, thank you for making the time and flying out for all of us patients and so forth. Feels a little bit misleading in that I feel like you guys are all Hall of Fame, like baseball players, so to speak. Do you know what I mean? And so to have you on a panel like this on a tumor board would be unusual. For us patients, if we're like in an area where there's maybe luckily having one all-star, then they have a tumor board with a bunch of bench players and minimum salary folks. Do you know what I mean? It's like, how do we, and no insult, but like, how do we compile our treatment, you know what I mean, so that we can get exposed our case through like an all-star panel like this? Because, I mean, you're at UPenn, you're at Swedish, you're at MSK, MD Anderson, I'm sorry, you know what I'm saying? So, how do we do that as patients? Does that make sense?
I would turn around to Julie. So this foundation is imperative to that kind of streamlining for patients with this diagnosis. I get emails from Julie on the weekly for this exact reason. The most common patient I see, and I'm assuming most of us see, their second, third, fourth opinions for that exact reason. That's what we're here for. I'm very happy to review a colleague's kind of plan of care, testing that was done, agree or disagree, and give comment. That's the easiest way to do it. The unfortunate truth is we've been trying to organize a virtual tumor board. That's very hard to do. It's like herding cats. But the easiest way is seeking second, third, fourth opinions and kind of figuring out who those people you may want to speak to. The MARF Foundation, IMIG, these types of groups are a great resource.
And there's nothing wrong at all with seeking several opinions, right?
So actually, this is something the board has, I'll speak for the board, is very interested in. We're talking about this idea of meso centers of excellence, and certainly that's something I think this organization can work to provide. There are a lot of hurdles that really don't allow us to do telemedicine and other things. For example, I was raised in the area where touching and laying hands on the patient was critical, and how dare you diagnose a patient you've never seen. But by and large, we can get a lot of things right on a telemedicine visit, and we kind of learned during the pandemic I diagnosed a pulmonary embolus very early in the pandemic because the person was looking funny, and I was like, does anybody have a finger oxygen monitor? Like, oh, I just got one from Amazon. Like, put it on, and now run to the ER. You have a pulmonary embolus. So there's a lot we can do. We're currently, so as an organization, that's what we're here for. We're working on that. I would also say for advocacy, everyone is trying to put hurdles back up, or many people are trying to put hurdles back up. The federal government, different states are putting up hurdles so that we can't see across state lines, and we can't provide opinions, and I can't take care of my patients when they move to Virginia because I'm not licensed there, and then I have to find someone who knows about a really rare cancer, and it's very stressful. I think this is something in the modern world that is utterly unacceptable. There can be a person in the darkest corner of Appalachia with a perfectly good iPhone that I can give a great medical opinion to, and they can share their medical record with me, and I think it's unacceptable that we allow roadblocks to continue. And us complaining, physicians can't complain about doctoring not being any good or payment not being any good. Scientists can't complain about no research funding because it's too self-interested. What really helps is where patients advocate, patient groups advocate for these changes, because I think, again, if you can talk to your grandmother in Thailand without any trouble whatsoever. I've had conversations with people on the International Space Station. It is unacceptable to have an area where you feel like you're being treated by guys who ride the pine.
I think centralization in the care of certain diseases is very important. I think it's one of the things that Canada actually does very well in terms of mesothelioma. It's very centralized. I guess I'm lucky and unlucky to work in a place where we have a very large encatchment area. So I see people from Alaska, Montana, Dakotas, Oregon, Idaho. And I do a lot of the visits virtually, and it works out just fine. And when we need people to come in, if they come in once, it's way better than having to schlep in 4, 5, 6 times, right? And you're right. We can call space from Texas, for crying out loud. But you can't do virtual visit. It's nuts. So I think it's important to really push the virtual platform, because there is a lot of stuff you can do remotely. And as long as they have a good physical exam locally, that's fine. And hopefully they can pick up on red flags and things like that. But you can do a lot of directing and guidance of care remotely. And the best thing that might come out of it is you come up with an organized care plan that's put together by a bunch of people who are used to seeing something like this, and it gets carried out locally, right? And as long as the person locally doesn't have a major ego problem, then usually that's fine.
I do agree that it is probably for rare cancers particularly a second opinion, especially if this diagnosis was made in the community. To have the academic side is very critical, but it needs to be a true second opinion. So I would not recommend just a chart review. Pathology needs to be reviewed, imaging studies needs to be updated in an acceptable quality, because what really makes these centers maybe a little bit more meticulous is that it is a team effort. So I am as good as my pathologists give me the right diagnosis. So that is why it needs to be a true second opinion, not just a chart review. But this is a patient's right. It is not about physicians, it's about an individual's health. So that is why I would be very supportive of that. I do agree that it is not very easy for every state or patients to be able to travel, and foundations like this has been a great source. So it's very fortunate.
I just have one more question. Now, I'm the sports right, my daughter-in-law, but the question is, with the funding cuts on NIH, how has that affected the ability to learn from your colleagues across the country on what's going on in your field, or do you have your own kind of network that you deal with it? It's not that critical. And then the other question is, how are these clinical trials funded and supported, and how's that has that been affected by that decrease in federal funding?
It's a difficult question to answer on a recorded stage. The world continues to spin, medicine continues to lurch forward, and our patients remain our utmost concern. There are, in my colleagues' terms, a lot more roadblocks now than there were. Fortunate that we have several federal grants. I know many of us on the stage do. Mesothelioma in particular being the demographic that it tends to affect, at least on paper, the funding line there has not been as dramatically affected for some other areas of research like DEI and things of that nature. But it's definitely become a much more difficult environment to get substantive funding. Our ability to communicate doesn't change, thankfully. So I texted Melina twice last week about patients. We constantly talk. What will become more difficult will be the ability to do cooperative group trials with federal funding. And the way to combat that is the people sitting in this room in this foundation. Constant advocacy that this is important. This is not a partisan disease. Again, I'm not going to sit here and give my opinion on federal cuts in general because I have strong opinions. But for this specific disease state and the people affected by it, this should not be a partisan discussion. And funding should remain, in my opinion. And that's what we keep advocating for. I know Dr. Zouder is not on stage right now, but she's been instrumental in advocating for continued mesothelioma support. Last meeting, we marched on Capitol Hill to continue the support for this. I think it's acts like that that'll keep meso in the limelight as a nonpartisan need.
And just to answer your question about clinical trials briefly, so most clinical trials are funded by pharmaceutical companies that are making the drug. And that's great. They're amazing partners in this disease, and it's awesome that they're developing drugs in mesothelioma. So we enjoy partnering with them. It does leave out some of the questions that they're not interested in. Maybe it doesn't involve their drug, and that's where these cooperative groups come in. So trials with ECOG, Alliance, SWOG. These are names of cooperative oncology group trials. And those are the groups that have a significant amount of federal funding, and they are having some trouble with those trials. Thankfully, again, our industry partners are stepping up, and they are helping with those trials, but that's where we need the advocacy.